All right, good afternoon, everyone. My name is Jennifer Kastner-Thomas, and I'm the Coding Director here at SENTA Partners. Thank you for joining us for today's Lunch and Learn, where we're going to discuss the latest on telehealth. Before we dive into the content, let's quickly go over a few housekeeping items. First, this webinar is being recorded, so we kindly ask that all participants please mute your phones and computers to reduce the background noise. To ensure that we're able to cover all material during our designated time frame, we will be taking questions related to the presentation at the end of today's session. Also, the information that we're covering today is current as of today, and it will change as new information or clarifications released by CMS, the AMA, or any of the Medicare administrative contractors. Any questions related to this presentation can be directed to me, Jennifer Kastner-Thomas, at jennifer.kastner@sentapartners.com. All right, during today's session, we're going to cover a few key topics related to telehealth. First, what is the status of telehealth as of today? And for the providers, we're going to discuss the documentation requirements for telehealth. And last but not least, we're going to discuss how to code the telehealth services, as well as how the coding rules may vary depending on the payer. So as for a status as of today, you already know the future of telehealth coverage is currently pending approval from Congress. While telehealth itself isn't being debated, it is included in a larger bill that contains other disputed issues. During this period, while the government shutdown is taking place, telehealth services are considered non-covered until this bill passes Congress. To bill telehealth services compliantly during this time, certain requirements must be met before the service is rendered. Medicare requires an advanced beneficiary notice, also known as an ABN, to be issued, and some commercial payers may require similar or proprietary opt-out waiver. It's essential that these forms are completed in full prior to providing telehealth services. And hopefully Congress will vote soon so that we can move forward with our usual telehealth billing. I truly believe that telehealth is here to stay, and I will continue to monitor this issue closely. But please feel free to reach out to me if you have any questions or want to discuss this further related to your practice. All right, so for the providers, let's review the 6 key elements that must be documented for every telehealth visit. These details are essential to ensure compliance, support billing accuracy, and maintain the integrity of our patient records. The requirements I'm about to cover are required for all telehealth services, technically before the shutdown, during the shutdown, and even after. The only thing different during this government shutdown that, in addition to the items that I'm about to cover, an ABN or an opt-out waiver is required dependent on the payer. First, we must document the consent from the patient before performing any telehealth service. This isn't a one-time event. It needs to be documented at every telehealth visit. Payers require proof that the patient agreed to the service each time it's rendered. Next, we must record where the patient's located during the visit. For example, at home or work or elsewhere, because this helps determine the correct place of service code and also confirms that the payer is practicing within the state in which they are licensed. During COVID, we had waivers in place that allowed providers to render care via telehealth to patients in other states. This waiver has now expired, and providers must only render telehealth services in the state in which they are licensed. Therefore, if the patient is out of state, the provider must also be licensed to practice medicine in the state that the patient's in to be able to compliantly render that service. We also need to document the provider's location at the time of the visit, whether the provider's in the office or working remotely at home or another temporary site. This information must be included in the chart. And fourth, you'll need to specify the technology used to perform the telehealth service. Indicate whether it was real-time or synchronous or asynchronous. The documentation should include the platform's name and note whether it was audio-video, audio only, or remote monitoring. Remember, only HIPAA-compliant platforms can be used, such as Doxy.me, Zoom for Healthcare, Simple Practice, or Healthy, as well as any electronic health record system that has integrated audio-video capability. Platforms like Skype, regular Zoom, and FaceTime are not HIPAA compliant and should not be used for patient care. Next is the time. Some telehealth codes are time-based, so it's important to document the total amount of time spent providing the service. This helps support accurate coding and billing. And finally, just like any other E&M visit, the documentation must include a history of present illness and an assessment and plan. This ensures the medical necessity is supported and the continuity of care is maintained. When all 6 of these elements are clearly documented, the telehealth note will meet payer and compliance standards, reduce billing errors, and support high quality patient care. Next, let's review 2 examples of some documentation statements that a provider could use to ensure that their notes meet telehealth requirements. These statements clearly identify the type of technology used and help ensure your notes meet payer compliance requirements. So the first one's for audio video. It states this visit was conducted via real-time audio video telecommunication technology. The patient provided verbal consent for a telehealth encounter. Both the provider and the patient were located within Georgia or whatever state at the time of the visit. Again, this isn't exact. It doesn't have to be exact. This is just kind of a guide for providers to use to help them capture all of those elements that we covered in the previous slide. The other one is for audio only. And I do want to point out some payers do not reimburse for this service. I've heard that some of the Medicaid plans don't. But some payers do. So I do want to point out that if there is an audio only service, first of all, it's a last resort. Payers usually, want this. They prefer the audio video or in person. But if, there were plenty of times during COVID, what happens is the patient's not able to connect for some reason. So it's like, well, what do you build in? So for audio only, here's an example of a statement that can be used. It states this encounter was conducted via audio only communication as video was not available or appropriate. The patient verbally consented to receive services via telephone. The patient confirmed the patient's identity and a location, and both parties were located in whatever state. Again, these are just some guides. I recommend providers just use it as have it like a macro or something within the system, or actually I recommend, if it's an option, to look at having like templates within the system that are specific for telehealth, because you could actually tie the template to the unique place of service that's required for telehealth and modifiers. So if you're in the position where that could be possibly changed within your organization, you want to navigate those options, please feel free to reach out to me, because there are some options that we could do. Because ideally, we want to leverage the system as much as possible and not have to keep up with all these payers' rules and regulations. It's difficult, so we want to leverage the system when possible. All right, so now we're going to turn our attention to the coding for telehealth. In 2025, the AMA released new codes for telehealth services. However, not all payers have adopted them yet. This is expected to evolve as payer systems are updated, hopefully, because you know how it is. And payers can create their own rules and regulations, but it does make it administratively easier if payers are all on the same page. Because currently, like, for example, the codes I'm about to show you, CMS hasn't adopted these new telehealth codes. We still have to build things with the office visit code instead. And the way they recognize a telehealth code is they pay specific attention to the place of service code, 02 or 10. So yeah, if all payers were on the same page, it would significantly reduce healthcare costs. But again, this is where we need to work together to create some, edits in the system and leverage our system to help us keep up with all the different requirements. And we certainly don't expect our providers to keep up with that. We want them to focus on their quality healthcare for their patients. So on the next few slides, you'll see these newly released codes. And if a payer hasn't adopted the new AMA code, you'll see where I have a column that contains the crosswalk code of what it could crosswalk to for those payers. Again, it's critical to pay attention to the place of service codes and the modifiers, which can differ based on the telehealth modality. For example, whether the visit was conducted via audio video or audio only. There's a unique modifier for that, in which you'll see here shortly. Also want to point out Again, providers are not expected to track every payer update or memorize each payer requirement. This information has been conveyed to the coding and billing team and the AR team, and they've been instructed if a payer were to deny for this particular, like they don't take the new codes, the appropriate crosswalk to change the code to. Again, we would like to leverage the system more. So as the new year comes out and we see how payers are going to be handling telehealth, for example, are any of them going to, more payers, is Medicare going to adopt the new telehealth codes? Or are we still going to do the office visit? Whenever that is clarified for this new year, we're actually going to work with everyone, the coders and stuff, so that we could get these some edits in the system to help keep them, because ideally we want the claim as clean as possible from the get-go, from the very beginning. So for providers, in short, while the coding landscape for telehealth continues to shift, you can feel confident that our billing and AR teams are managing the details behind the scenes. And this is so that you could focus on providing that quality patient care instead. The first table reflects billing for audio only. Again, some payers do not allow audio only, and it should this modality should only be used in cases where the patient cannot meet face-to-face or via audio video. For audio only, the modifier to use is 93, and you will see for the new patients, the codes for the CPT codes are 98008 to 98001 for your new patients. And it depends, each of these levels, just like with regular E&M codes, providers could use time or medical, they could either use time or medical decision making for their level of selection. But I do want to point out, at a minimum, to be able to bill audio only, the provider, and not ancillary staff, but the provider must have spent at least 10 minutes on the call to be able to even bill for these services. And then here's that column that I mentioned, the conversion for payers that do not cover telehealth codes. This is these are the codes that AR and the coding team have been instructed that they could use instead. All right, so the next table shows that for audio video, the modifier is 95, and it codes for new patients for audio video, those are codes 98000 through 98003. For established patients, 98004 through 98007. And the same concept, provider could choose the level of service based on medical decision making or time. And then we have the column over here that indicates, the crosswalk if the payer does not accept that code. Again, Medicare is one of those payers that do not accept that. So, but hopefully that'll change in the new year and we could get some uniform standard across all payers. That would be great. It would save a lot of time for the coders and AR, everyone across the board. So again, another important thing I want to point out is the place of service code should not be 11 for office. When you perform telehealth services, it should either be 10 for home or 02 for other. We are in the process of identifying, again, how those payers are going to be processing these claims for 2026. And once these are determined, we will create some edits to help us get the claim clean as possible from the very beginning. Each payer is different, so we'll have to tailor the edits to be specific to them. For example, I mentioned modifier 95 is the modifier for audio video, but Medicare, literally the only thing they refer to for telehealth reimbursement is not only the CPT code, but they also look at that place of service code. They don't want the 95 modifier. So this is things that our coders and billers are having to keep up with and to bill it the way each payer wants it. So, but the important thing is we want our providers just to, if they could capture the modifiers, then we could create the edits to catch these claims and fix them to be the way the payer wants them. But for now, the takeaway for now is if right now telehealth should be on hold, but if your practice is looking at, a handful of unique situations where they may want to do telehealth, the patient wants to, and they want to pay out of pocket, there's a very precise procedure we have to follow. So I want to meet with y'all. If your practice is doing that, let's meet, let's talk about it so that we can make sure those processes are in place. Because the ABN has to be signed. We have to put an ABN modifier on the claim, and we still have to bill the claim to Medicare, and we have to get their they have to officially put it to the patient's responsibility. But for government payers, the claim still has to be billed. So please don't hesitate to reach out to me if you have any questions about that, or if we need to talk about incorporating it into the workflow. But for now, I am going to turn it over to you guys to see if you have any questions. They're probably, this is where we find a lot of answers, is those unique situations and scenarios. We could talk them out. So I want to open it up to you guys. Do you have any particular questions at the moment? I'm going to go ahead and stop the recording.